Thank you, Vince. That was great. Our next presentation will be a 20-minute presentation from Biodent, and it's Robert Rutner.
Good morning, everybody. I assume in this crowd there are some docs that place implants. I also assume there are some docs that want to place implants. This presentation is for both of you. Where's my... So the implant that we have, Biodent, it's called the Ultratooth. It's not a new product, actually. It was invented about 25 years ago. And over the last 10, 15 years, we've been developing, frankly, a better product. We've looked at the styles of implants over the last course of time, and we've improved upon it. So this article from 1991 talks about the basic concept of this implant. So as we can see, it's not new, but it's new to you. So as you can see, this implant looks a little bit different. It's not a screw. It's a very simple implant. And you can see on the lower right, what it is that this implant expands. And because of that expansion, we have some unique parts of it. Unique things happen because we can expand it. The design of the Ultratooth implant, again, is different. As you can see, there's multiple parts and multiple screws within this system. So this is not a simple one-piece implant where you just screw it in and then screw an abutment on top of it. With this, we have an interior screw. That interior screw that you see at the bottom of this implant on the inside, that's actually there to expand the implant. And we're going to see a video of that in a minute. The next screw is one that actually seals the top. And the last screw, the top screw, what that does is screws the abutment in. So there's actually 3 screws in this implant, and they all have unique parts for this. We also have an external Morse taper with a typo. It's not a tapper, it's taper. Many of the early implants had problems with fracture of the table. So we looked at that and decided to have an external Morse taper, one that goes over the top of it. So fractures of our implant are virtually non-existent. The other interesting thing about this system, and most of us who do place implants, we have a ton of parts. Most implant systems have lots and lots of different cuff heights, widths, etc. Ours has only one. So what we have is we have a small abutment, and that can screw into the top. Basically, use that if you have a lateral or someplace where you're really skinny for space. A provisional abutment that comes in the package, and with that, I affix my temporary or long-term provisional on. On the right, with the angle, that's an abutment. And that actually comes in the package as the form of the carrier, which is to its right. And with the carrier, you can actually cut it down and shape the abutment whichever you want. So in the package, you actually get the final abutment, you get a provisional abutment, and all the parts that you need. Then you can see the screws, the 2 screws on the lower right. Those screws, the bigger of the 2 screws, we call a screw cap. That actually seals the top of the implant. When we go to expand it, that then goes to seal it afterwards. And then the small screw is actually the abutment screw. With all of our screws, because we have such a snug fit, you do them just hand tight. Other than the expansion screw, which will torque to 20 newtons. Everything else is just hand tight. None of this trying to decide whether it's 25 or 30 or 35 or 32 newtons, just hand tight. So what we're really talking about is single visit tooth replacement. We have developed an abutment for a CEREC machine that you can scan and immediately make a final restoration if you so choose. So now we're going to see a short video. We have very catchy music too. So here's a tooth
Use
that
proper elevators to perform an atraumatic extraction, preserving the original contour of the hard and soft tissue. A handheld or ultrasonic curette can be used for socket debridement.
it's important that you clean out all the remnants of anything within
After placing the surgical stent, the universal one-step drill is inserted to the proper depth and direction. The final drill is then used to establish the final depth and direction of the implant site. The Emergence Profile Counterbore drill is used to remove any hard or soft tissue tags from the future abutment position. The hand wrench is used to drive the Ultratooth and the carrier into the site. After placement, the Ultratooth is locked in place at the bottom of the bore. The UT hex driver is then used to remove the abutment screw. The UT hex driver is again used to lift the carrier by loosening the screw cap of the Ultratooth. The carrier and the screw cap are then removed. Initially, the expansion screwdriver is hand-torqued to initiate the expansion of the pods. The torque wrench is used to finalize the expansion. The head of the expansion screw establishes the first seal point. After 20 newtons of force, the head of the torque wrench automatically breaks. This keeps from overexpanding the Ultratooth. The screw cap is hand-tightened with the UT hex driver. This establishes the secondary seal point by using a Morse taper. The carrier can be prepared into an abutment outside of the oral cavity. The abutment is placed onto the Ultratooth, and the UT hex driver is used to tighten the abutment screw. This is the tertiary seal point by a proprietary hex Morse junction. The abutment can be refined using a diamond drill with adequate irrigation. At this point, either the provisional or final crown can be cemented and used for full function.
So as you can see with this implant, the simplicity of it, that basically we're not really an implant company, we're tooth replacement. Patients walk in with problems every day. They walk in with a tooth in their hand. Many times it's a tooth that we crowned 10, 15, 20 years ago, and it's now in their hand because it's snapped off at the gum line. And we know now that our options to fix that are limited. But now we can have them walk out with a tooth in about an hour. So the benefits of this implant, number one, full functional immediate load. And we mean that. You'll see in our videos that we actually, if it's an anterior tooth, we'll have a patient bite an apple right after placement. It's that secure. Two, preservation of original emergence profile. The standard way that implants have been done for an anterior tooth generally is take the tooth out, graft it, wait 3 or 4 months, place your implant, wait 3 or 4 months, then finally make a tooth. The problem with that is you tend to lose bone at the coronal aspect, and then you lose bone, you lose gum tissue. And when you lose gum tissue, then you get the black triangles that patients look at and say, well, why do I have those? Well, it's because of biology and physics. That's why they get them. But with our implant, because you're placing it right now and you're putting a temporary on right now, you don't lose anything. It looks exactly the same. So you don't lose coronal bone due to the Eiffel Tower effect, which allows you to maintain that original emergence profile. When you expand the pods, you actually increase your bone density. And our studies show that after a course of time, bone density continues to increase. You also get 30% more surface area because as those pods expand, you get bone growth on the inside and the outside of the pods. So let's look at a case here. This is tooth 8 and 9. Here we went ahead and placed 2 implants immediately within the extraction socket, although the expanded portion is always in new, fresh bone and is typically palatal, in this case, to the extraction socket. And this is what it looks like 7 years later. And this is something that's spectacular because most implants won't look like this. And again, here is a study after 40 months that just how good these implants and the teeth on them look. I'm going to cut a little forward and show you a live surgery. This is an interesting part here where 2 ailing implants and a bad tooth. The tooth was extracted, 2 implants were put in, and you can see here 6 months later, the bone surrounding the ailing implants is even better. Okay. Apologies, the laptop's cutting off some of my data here. All right, here we go. So many times we ask, can this implant only be placed in sites that are non-infected? So in this case, I'm going to show you a picture, a video of one where it's obviously a bad tooth. We can see it on the radiograph. We're going to take the tooth out as atraumatically as possible. In this case, this tooth is infected. We can see that. In this case, also, only half the root's coming out. We check the buccal plate. The buccal plate on this one is missing. You can still place this implant at the same time as long as you have bone above it. So here what we see that missing buccal plate, we've curetted out all the bad tissue. Remember, this is a patient that wants a tooth today, and we can provide that. With the universal drill, it's an amazing first drill. Press it, run it at about 800 to 1,000 RPM, and it just sort of guides into the area where you want it to go and make sure your angulation is correct. Then with the second drill, again, everything's pre-measured with ours, so it's a very, very fast, simple procedure. Then we're going to go ahead and use an emergence profile drill. Many times that palatal bone is in the way. So here we're just cleaning that off, and now we're going to place the implant. The implants are put in simply by hand, and now we're going to torque it, that inside part, to 20 newtons. Go ahead and do your grafting, whatever you choose. So graft around the implant. And again, you can use BioOs collagen. I typically use NovaBone, any sort of membrane that you choose over the top of it. Calcium sulfate, that works too. Whatever works well in your hands. In this case, calcium sulfate with a little bit of tetracycline in it. Again, our goal here is to keep all of the architecture exactly the same. Now we're going to carefully reposition our flap. And sew it up. And now put on an abutment, and then a tooth. And this is just simply an acrylic temporary that is made much like you would make a temporary for a any other crown that you would have. You can take an original PVS and make it that way as well. I commonly will use the patient's crown that I just took out, reline it with composite, and here she goes. Every patient is amazed that they can do that. So, as we embark on this next course of time with implants, every implant manufacturer is trying to find solutions. And truth is, every implant has a solution for some part. I use this implant in all the anterior areas, and the reason for it is that every patient wants a tooth right now. Nobody wants to wait on them. In almost every case, you can place this implant and a tooth right now. I've gotten my practice to the point where we can extract a tooth, clean up the socket, place the implant, take the impression, make a temporary, and it takes us about an hour. And at that point, then we're done. Patients come back in 2 weeks. In 2 weeks, I tap on the implant, make sure everything feels good. In 2 weeks, they come back after that, and we put their final tooth on. But they never are without a tooth. So again, thank you very much. I appreciate it. We're booth 2125. I look forward to seeing you at the booth. We have some brochures on the side, too. Thank you.